Dr. Ndileka Mbete. She's the Managing Director of Chamo Health. Her topic is on demystifying value-based care, a GP perspective. Dr. Ndileka is a medical doctor and experienced healthcare professional who is passionate about population wellness and an advocate for health equity and patient-centered care. She seeks opportunities to create systematic change in how patients access quality and affordable health care on the African continent through advances in technology and care delivery and funding models which promote improved outcomes and enhance patient and provider experience. I need to breathe. She has considerable experience in designing and implementing value-based care delivery and funding models in both primary care setting and hospital care. She works as a healthcare strategist, designing and providing program implementation support and in primary healthcare, maternity and chronic kidney disease for clients in South Africa and neighbouring countries. Dr. Ndileka, over to you.
Thank you so much, Joey. Good afternoon, everyone. Can you hear me okay? You can. Thank you so much. I think Dr. James mentioned it's always a bit tough talking after lunch because of the postprandial. So I thank you for your attention up front. So I'll be talking about value-based care today. Thank you to the conference organizers for the opportunity to speak about this topic. I think as private health systems across the globe are struggling with a couple of things, and we are no different. The cost of healthcare continues to rise, and the outcomes are not necessarily rising with those costs. And so value-based care sort of really brings us back to this conversation about how do we think about creating value for our patients. So just a brief sort of overview of what I'll be talking through, really around how do we think about value, defining value, what is value-based care, then also really thinking through how we apply it in the context of complex patients, because I think that's where really the conversation around value-based care really comes alive. And then also just want to take you through a little bit about what contracting for GPs looks like in value-based care. So how should we define value? When we speak about value, is it value for money? Is that what we're talking about? Is it that someone is satisfied that the money that they've parted with and the services that they got, they feel that they're happy with that sort of interaction? Should it be around the quality of service and the satisfaction with outcomes? I think in a lot of other sort of service-related industries, it's a little easier to define, and I think the notion of value is often quite subjective. It depends. I mean, if you've got a very well-defined product or service that costs this amount, you can try and see whether is the customer satisfied with that or not. In healthcare, it's a lot more complex. But I think these are some of the questions that, because a large component of it is subjective. When we speak about patient experience of care, when we speak about patient satisfaction, that is a subjective measure of the value that they believe that they got from the healthcare interaction. But we also have to ask, should it be measurable? Should it be objective? Should we be able to quantify the value that we've created? And so, I mean, I think in healthcare it is complex. Healthcare is very complex. We all know, I mean, human physiology, pathophysiology, pharmacology, the healing process is very complex. And when we think about economic terms, such as is healthcare a normal good? It's not a normal good. Economists talk about a normal good is really something where as the person's income increases, their desire to purchase more of a particular product increases. Now, healthcare is not, you can't say that. As someone gets richer, they don't suddenly develop an appetite to consume and buy, more healthcare. I think what also confounds the complexities in healthcare are there are many points of information asymmetry. We don't all know the same things, right? So patients and doctors The doctor knows, the patient might be, is the expert of their lived reality, right? But the doctor knows a lot more about physiology, about pathology, than the patient does. And that skews almost a balance of information and power. Similarly, patients, there's a huge imbalance between patients and medical aids. I mean, if you think about any patient, if you think about in November, when your medical aid sends out that notice of you can review your plans, there are so many different plans, and under each scheme, each of the schemes are very different. You can't really compare scheme 1 to scheme B to scheme 3 and compare what they offer. So I think that's a huge complexity that's difficult for patients to navigate. But I think similarly, it's difficult for doctors to navigate because we also don't really know the differences between these different plans. Will they pay for what I want to provide, the care I want to provide for my patient? We don't really know. So I think in a typical GP practice, I mean, there's a diversity of the patient profile. So you've got the young, healthy patients who come in typically for acute care, and their definition of value would probably, they got healed for that particular acute event, and they are discharged. You get older, complex patients with multiple comorbidities, and they're coming in for chronic care, right? Now, how do you define value in these two different groups? Would you use the same sort of measures to define that value? To further sort of add to the conversation, what would the doctor's perspective be on the value created for those different patients? And I think typically as clinicians, we'll speak about certain biomedical markers. We're tracking certain things which are clinically important to track. Patients, some of them are comfortable with those terms, most not. And you'll find a complex patient is probably thinking for themselves value. If you think of an elderly woman, multiple comorbidities, she wants to know, can she still go to church? Can she still go to her church women's group on Thursday? Will she feel well enough to still continue picking up her grandchild from school? So the idea of how patients define value becomes very, very important. Just to bring us back to, because one of the things that value-based care seeks to move away from is fee-for-service, right? And you think about how we were, what is a clinician's why? Why do we go into healthcare to begin with? And it's really around, the call to healing. We're intrinsically motivated to want to try and do the best for our patients. If we go back to our public sector training, most of us train in fairly, whether it's urban or peri-urban sort of situations, you're a little bit more connected to your patient's realities. Clerking a patient takes as long as it takes. You have access to multidisciplinary team care. It's easy to call in a social worker if that's what if you can see that the social determinants of health are playing a huge role in this patient's sort of profile. It's easy to call in a dietitian, a social worker. In private practice, particularly solo practice, that's quite difficult to do. And so the question we have to ask is, are we able, in a fee-for-service paradigm where you've got 15 minutes, most practices work on a 15-minute booking schedule, are you able to create value for patients in that 15 minutes, particularly if it's a very, very complex patient? If you think about an elderly, again, that elderly woman I was speaking about, could be an elderly male, the history alone will take 15 to 20 minutes. The social history, which is critical to understand, the level of social support that patient has, and all those things, that alone takes about 15, 20 minutes. So we really have to start thinking about that a bit differently. So what is value-based care? Here are a few sort of, and I'm interested to hear from everyone in here, which of those resonates? So I appreciate that there'll be varying degrees of familiarity with the term value-based care and what it is doing. So who sees it as a cost-cutting model, or that's how they've heard it being spoken of? Cost-cutting, it's all about cost-cutting, value-based care. Not really. Part of it. Is it about paying for performance? Very active here. I'm gonna swing my attention to this side. Is it pay for performance? Is it about fixed fees? Is it about capitation? So I'm seeing some nods to quite a few of them, which is saying that it's some of those things. Some of those things come into the conversation. So, the value equation is really thought of as patient value is really looking at the quality of the care that we provide, and that's both hard clinical outcomes, but also patient experience of care outcomes, and the outcomes that matter to patients. If I go back to that old female example, yes, it's great that her GFR is within and her HbA1c is within limits, but she wants to feel vital. She wants to feel she can still participate in community and family life. And so those are the outcomes that patients really want they want from healthcare. It's also then, so it's quality over the cost of producing those outcomes, right? And so cost is obviously the inputs and all of that, but it's also value-based care seeks to bring in the indirect costs. So when patients, their transportation costs, the loss of productivity costs, it wants to bring those into the conversation as well. So clinical outcomes and outcomes that matter to patients over the cost of delivering these outcomes. So why does this matter? I think I started off with, the cost of care is rising, and there are a lot of problems in private healthcare. There's over-servicing, there's over-utilization, a little bit of waste, and these are problems that are driving the cost of care up, right? But part of that is this fee-for-service paradigm. If you've only got 15 minutes for a consultation, and you're only going to get It incentivizes the behavior to produce volume, to push volume. You do more things. You do more tests, the patient must come more. And the problem with it is it's not really incentivizing outcomes or incentivizing clinicians to coordinate care. So what value-based care really wants to do is to say, let's focus on the quality of the care, not just the volume and the amount of things and stuff that you've done for the patient, and a focus on the improved outcomes, but at the appropriate cost. So it's not cost reduction to no end and at all costs. It must be at the appropriate cost of care. But I think it also seeks to address the wider determinants of healthcare, not just clinical care. So I'm going to speak a little bit about complex patients, because I think that's where the concepts really sort of start to land. And we know that, in SA, we've got a rising burden of disease, of non-communicable disease. 51%, this was published in the South African Renal Registry annual report. So 51% of CKD is attributable to hypertension and diabetes, right? What we also know is that there is not enough screening, and we're not finding these cases early on enough. This was a study that was published in the Journal of Population Nutrition, Population Nutrition. So what they did is they took South African demographic health survey data. The study participants was a group of about 6,000, let's call it 6,000, just under 6,500, aged 15 years or older. And they really did two things: HbA1c testing, and then they also did a couple of surveys that look at social determinants of health. And the outcome variable was really the diabetic status, trying to get a sense of the diabetic status. And the outcomes were that 11% were found, and these were in patients that had not been previously tested before. So 11% were found to be non-diabetic. 22% were found to be diabetic. And 67% were pre-diabetic, right? I mean, it's a worrying stat, because what it says is that if this survey hadn't been done, chances are those patients in that middle block, that 67%, will go undiagnosed for many, many years. As they are going undiagnosed, the disease is progressing, right? And so you're likely to catch them when they present either in casualty, or they present with some sort of other, critical or catastrophic even medical event. And so it's really, really critical that we don't miss the opportunity to intervene early, but also to keep patients well. Keep them well, keep them healthy, keep them productive in both their commercially productive, but also productive in just their family and their community lives. So this slide really just looks at what are the cost drivers so that patient who was undetected and is now found with already CKD. You can see from the dark blue that from stage 1 all the way up to stage 5, the hospitalization costs are the biggest, the bulk of the costs in caring for these patients, right? The yellow are sort of the doctor professional fees. The other really big cost you can see from stage 5 is ED-related costs. So the opportunity really is in that stage 1, even pre-stage 1 and 2. And it becomes really, really important. I think the next speaker is speaking about prevention and screening. It becomes really, really important for targeted, proactive screening in these patients so that we're catching them before stage 1 and 2. And if we do catch them and they're already progressed on CKD journey, we're keeping them in that stage 1 and 2 or in stage 3 for as long as possible. Just some scheme data, so from Discovery Health, between 2019 and 2024, it corroborates this really, that 70% of the expenditure was really in the hospitalization costs. So what then is the GP's role in value-based care, right? And I think it's around providing, the GP is really the family practitioner should be the center of any family's sort of, is the caregiver, the primary caregiver. So it's providing that targeted, preventative, and proactive care. It's also optimizing chronic disease management, improving care coordination, but also educating our patients about their conditions so that there's an element of self-managing. Patients are able to self-manage and not run to, the emergency department all the time. And it's really about wellness. It's really about trying to maintain and keep patients as healthy for as long as possible and for them to be, productive for as long as possible. But what that does is that it reduces all the many trips to the hospital, many trips to casualty. And what that also does is that it reduces the cost of care in the long run. So what happens when care is not coordinated? I'm hoping that this slide looks like pure chaos. It's supposed to look like pure chaos. And the point really is that if you think about a complex patient with multiple comorbidities, they've got their GP as their primary caregiver. They may have a physician, there may be a nephrologist, there may be a dietitian, and all of these people are in different places. It's all very fragmented. The patient doesn't really know when they must go to which one for what. When they do go to the physician, the tests that were done by the GP last month are done again. When the physician refers them maybe to a nephrologist, again, the same tests are done. They might then go to radiology, they might go to ED, so it really is chaotic. And I think the point about it is that when care is not coordinated, there's duplication of services, because each of these clinicians can't see what the other one did. There's a lot of waste. And the waste is important because, I mean, the patient has X amount finite benefits that the scheme gives them for the year. If Dr. A, Dr. B, Dr. C are all do a full blood count, do a full UNE, do a full, I mean, that depletes the patient's resources, right? So that's wasteful. That is wasteful. But also it's lost productivity because as the patient is being referred to these different places, that's time away from work. That's time away from their life. And so what should coordinated care look like? Particularly for complex patients, we should be thinking about, you know that you need to look after them for a particular episode. How do you think about what is that episode of care? And I think a fair measure is to say, okay, so the episode of care is a calendar year. In that calendar year, how do we, it's really a care plan. What is the care plan for this patient? How many times will they need to see the GP? Will they need to see a physician? Will they need blood tests? But it's also communicating that clearly to the patient so that they know that at this interval, you will go for this. At this interval, you will go for that. And so that the patient is more engaged in their own healthcare journey. They know what to expect. And they can communicate that particular care plan to the next doctor as well if they are referred to more specialist sort of treatment. So this brings me to sort of the idea of population health management, right? So the WHO defines this as it's a people-centered and proactive approach to managing the health and well-being of a defined population. That defined is very important. By identifying subgroups with similar characteristics and needs, population health management can enable primary healthcare providers to move from a one-size-fits-all approach to targeted and tailored interventions that account for the needs of different groups and individuals. Just to check, who in the audience, who is a GP in private practice? Of those in private practice, who has electronic health records? So mostly electronic health records. And I mean, it's an important thing because I think doctors who do not have EMRs, you're sitting with a lot of data in your practice, right? Every single one of those health files is data. But it's not data you can extract and use. You can't analyze it. And so this is where EMRs become really, really important because in as much as a GP will know that when Umam Kize walks through the door, they know that this is Umam Kize, I know her family, I know her. They only can identify that when she walks through the door. Ideally, where you want to be is where you're able to look at your patient population, see it as a population, and you should be able to answer, what percentage of my patients are diabetic? What percentage of my patients are complex, high risk with multiple comorbidities, right? You should be able to see what percentage of my population are rising risk, only 1 or 2 comorbidities, but I need to target, certain screening and interventions for them. And then also what population are low risk, young and healthy. It's a different approach, but you've got to be able to segment your patient population. And it's difficult to do if you don't have the data. And so the goals really of population health management are around proactive, preventative, and targeted care to these defined subpopulations of patients. It's improving the long-term health outcomes in the targeted populations, and then also improving the overall patient experience of care and the outcomes which matter to patients. And ultimately, it's also reducing the cost of healthcare. So what does what does contracting look like? And for those GPs in private practice, do you belong to any population health programs, for any schemes that you do? Okay, so I'll talk to a little bit about, because I mean, I think one of the questions I asked when I asked what is value-based care, is it capitation, is it, performance payment, what really is it? And I think it's important to understand the risk journey, because you don't just arrive at capitation. A system needs to be ready for capitation. And so really these are the different, so the red is where we are. That's the predominant paradigm, is fee-for-service. And the gray represents the payments at risk, where we've moved from fee-for-service. So traditional fee-for-service means it's the volume of patients that you see at a particular price, and that's how the practice makes its money, right? And there's no risk there. There's absolutely no risk. The next sort of transition is where there's upside risk. And I think upside risk is the right place to start if you're moving, clinicians from fee-for-service. And what upside risk means is that your revenue for your fee-for-service is protected. Schemes are not going to touch that. What they will do is that this talks to the upside of the risk. What they will do is that they will give you an enhanced payment for doing things which will create value for your patients, for certain screening and stuff like that. The next phase, which we're not there yet, but I think it's an important journey to understand, because this is where schemes will migrate towards. So the next phase is really where there's upside and downside risk, where you're earning X amount for fee-for-service. You will earn an additional amount if you do generate value and you produce good outcomes. But by the same token, if your practice is falling behind its peers, you will then lose some money. That's not where we are right now, though. And then the full spectrum of risk-based contracting is really capitation, which is really getting X amount per patient per month, and you are responsible for managing those particular resources and keeping your patients healthy. So the clinician in a full capitation model is incentivized to keep the patient healthy. You're not going to earn more if they come 5 times that month. You're only going to get X amount for that month for that particular patient. So this is where we currently are in SA with certain schemes that are doing value-based contracting. So, the principles of most of the schemes and how they contract, it's similar sort of principles. They want the GP to be the nominated GP, because they need to attribute members to your practice. So you've got to register and sign up as the nominated GP, or your patient must tick that you are the nominated GP. So most contracts, that's what they need. They also need the ability for clinicians to start forming some sort of multidisciplinary teams. So I think the era of sole lone clinician working alone is gone. You've got to be able to bring in the services, a task shift, bring in the services of a nurse to do the blood pressure and whatnot, because it's within their scope of practice, but you will achieve the same thing at a lower cost. You've got to be able to bring in a dietitian, because maybe that's what the patient needs. They don't need a doctor in that interaction. So the ability to form sort of multidisciplinary teams is important. They then want you to be able to think about your patients as a population. And back to, I guess, the call for making technology our friend and having that data at your fingertips, it comes to, there's this concept of risk equalized performance indicators. And what that really is talking about is if you've got a patient population of 10,000, and Discovery or GEMS or Fed Health is comparing you to a similar practice, You've got to be able to say, no, but my patients are much sicker. Maybe you practice in an area where the predominant of your patients are predominantly elderly, multiple comorbidities, much sicker. That's harder work, right? That's a lot harder work to produce particular outcomes than someone who works in a very affluent area, young, healthy population. You can't compare those two practices, but you've got to be able to have the data to support that. So, can you hear me? Yeah. And so this risk equalization is then they're really trying to compare your performance to that of a similar practice, which they will then deem your peer, and what outcomes are you producing. And most of the contracts, they'll then put you into a tiering system, whether you're tier 3, 2, or 1, level 3, 2, or 1, and the objective is really to try and become a level 1 provider, because then you get an enhanced fee, the fees associated to the tiering system. So they will pay you an additional fee in conjunction to whatever it is that the contracted GP consultation fee is. So just two examples of this in population health programs. GEMS has a population health program, and it's just an acronym for that risk equalization performance indicator. And so you'll earn a different fee but again, the thing is, it's around incentivizing clinicians to produce better outcomes. Discovery has a similar approach where per patient per annum, they are incentivizing good glycemic control. So you will earn an additional 1,200 Rand per patient per annum whose HbA1c is within range. Also 300 Rand per patient per annum where the disease stage has been stabilized or improved. Many schemes, I think, because of, I guess, the issues with fraud, waste and abuse and overutilization and overservicing, the value-based care journey is well underway. I think that it's important for GPs to understand these concepts, to participate. The voice of clinicians is not in the room much. A lot of these initiatives are being driven by funders and by policymakers, and we really need clinicians to be in the room and part of the conversation. So I think to go on a value-based care journey, just a few sort of key enablers. This is not an exhaustive list, but just, the key things that you need. You've got to move away from solo practice. You've got to be able to bring in different levels of clinicians into how you deliver care for your patients. You need the support of IT systems, and you need data. You need that data to be able to analyze, segment your patient population, and target the appropriate interventions to your patients. And you've got to be able to stratify your patient population. And really, the key questions is you've got to be able to say, who are my riskiest patients? Because you've got a wide variety of patients, but you've got to be able to say which ones are at risk, which are the riskiest, and how do I think about being more proactive with those particular patients to keep them out of hospital, to keep them out of casualty, and to keep them stable for as long as possible. And you've got to understand, why are they risky? So all the social determinants, and then what's the best intervention for them. So where to really from here? I think for GPs that are contracted in to medical aids, or where the bulk of your patient population is medical aid, you've got to be able to think, which is the biggest. The English is gone. Which is the biggest medical aid in your practice, right? Which that your patients belong to. Then you've got to find out what are the population health management programs that medical aid is running. What are the screening benefits that they are running? What are all of those things. Then you've got to be registered as a nominated GP with that particular scheme so that you can benefit from some of these incentives. And then you've got to align your practice strategies to those incentives of that scheme. For GPs who are not contracted into medical aids or who have a patient population that is uninsured and largely cash paying, I think there are very unique opportunities for designing value-based care, sort of baskets of care that offer a lot of price transparency at fixed fees. I mean, there are a lot of things. You can do women's health things. You can do things around chronic disease management. And I mean, I'd love to chat to anyone who's interested in that. But I think for all GPs, you've got to upgrade your practice management systems. You've got to make data your friend. You've got to be able to analyze your patient population and profiles. You've got to be able, because I'm not sure which speaker it was. I think it might have been the speaker on AI was talking about if you belong, you can log on to Discovery Health or whichever other scheme, and there's a dashboard. They know the data about your patients, probably more than you do. You need to have that data. You need to be able to respond to whether it's a query from a medical aid. If you feel that you've been put in a risk equalization group or level and you feel that it's not fair because you have a much sicker patient population, but you've got to be able to motivate for your practice and for your patients, and you've got to be able to have the data to do that motivation. So you need to invest in those practice management systems. And then I think also, doctor, the point I made around the clinician voice is absent in a lot of these discussions. So find out what is your IPA, what are the discussions are being had there. Where are there opportunities to lobby with schemes, to be part of co-creating? A lot of schemes are actually very open to co-creating. They just don't know where to find GPs. They don't know. They know where to find some of them, but there are a lot of GPs, particularly if you're like in a peri-urban or rural or township setting, they don't know how to find you. So I think it's important to check with SAMA, check with your IPAs, what conversations are being had around value-based care, and join in that conversation. Thank you very much. Please feel free to connect with me. You can just scan that QR code and any questions that you may have.
Thank you so much. Any questions? Oh, we've got one there in the front. I'm coming.
Thank you for the talk and sort of elaborated on what value-based care is about. I just find that there are some challenges in terms of this, because it also depends very much on your patient population as well. So, in the more affluent and more educated population, they probably sort of base more value on looking after their own health. But if you're really struggling to put food on the table, you're not going to go for a preventative, you don't have time. Your employer probably doesn't give you time off to do that type of thing. So it will be harder as a GP or a care practice to look after patients that really don't have the time or the energy or the finances to be able to look after themselves properly and manage, say, for example, the HbA1c adequately, right? So that's the one challenge. The second challenge, you incentivize newly qualified GPs to find practices where they can do that. So they will people will move away from rural areas, because, I mean, if you're going to travel 100K to go and see your GP, you're not going to go unless you're desperately ill. So those are the concerns with this type of risk stratification, and that the third one I'm talking about is that GPs really don't get paid enough to actually have time to sit down and explain and educate the patient and talk about diets and looking after them from a primary health care point of view. And they really need that. To start off this on the right foot, any patient, to start on this type of value care, you actually need to know them inside out. You need to educate them. You need to discuss with them what promotes health, and also have time to ask them why they don't want to do it, and the barriers to not being able to look after their own health. And everyone's different. It needs time. 2 hours you need to sit with them and talk about this. The GPs are paid for 15 minutes. If they spend 2 hours, they're not going to get paid that. So those are the challenges that I can think of offhand, right?
Yeah. No, I mean, I think you've highlighted some key, and you've made the case for data. You've made the case for task shifting. You've made the case for a couple of things. And you're right, like in a peri-urban, in a rural practice, or where it's a less affluent, there are barriers to a lot of these things, right? But then it makes that each interaction, each care interaction, how do you maximize it? But you can only, and this is where I say you've made the case for data, is that if you have that data at your fingertips, when they walk in that door, you know they are an at-risk patient. So you will, even if they came in for flu, you will do a dipsticks to see if there's any microalbuminuria. You will do, you'll check for glucose, you'll check for hypertension, because you know that they might not come in or they might not have another care interaction. So it's how do you seize that opportunity for each of those very limited care interactions to create value for the patient. Your point around how do you do that in 15 minutes? Absolutely, right? Because that's the problem with fee-for-service. But then there's where I would say maybe you're building a case for task shifting. Because in your practice, it can't be that the doctor, that's the most important resource, not important as in hierarchy of important, but that's the most expensive resource. It can't be that you are doing the education, plus the blood pressure, plus the urine dipsticks, plus the... So when you think about your practice and staffing your practice, is there a nurse assistant? Because as long as you're keeping within scope of practice, how do you shift some of those tasks so that you have more time to sit with the patient for the things that really need a doctor? The other things that don't need a doctor, which could be done by a nurse, by a nursing aide, by a nurse, should be shifted appropriately. But then, again, it's back to you need good EMR, because then do you have a shared view of all of that data? If your nurse is writing, if the patient arrived in the rooms and the nurse did the blood pressure, did the urine dipsticks, by the time that patient is sitting in front of you, you should know their risk profile. You should also know what all of those investigations showed. You know, it can't be, because you've only got 15 minutes. So we need to think differently about how we staff our practices so that we can task shift appropriately, and maximizing that one interaction in those settings. Yeah.
Sorry, can I just add more comment to that very valid response, is that the GPs then, because of their expertise and using it effectively, they need to be paid a lot more to be able to task shift. Yeah. Otherwise, how are they able to afford to get another person in that increases their practice costs? Yeah. Okay, so yes, okay, you can do that, but then there needs to be a paradigm shift towards Absolutely. How GPs get paid and how that type of practice is reimbursed, you know?
Absolutely, and I think this is why we need doctors in the conversation when funders are designing benefits, because you're 100% right. You need to be compensated. I mean, the attempts with some of the contracts are trying to do that, right? They're trying to say, you know, you'll get paid extra to do X, Y, Z. One of the critical components of value-based care is care coordination. And it remains a challenge in that who pays for that? So, and one of the things to make it easier is task shifting. So you're not asking for the doctor to call and follow up and coordinate the care and make sure Mum Kiza goes to the physician on this date. It's someone else in the practice, but it's a task that needs to be paid for. It's a task that has been recognized as creates massive value in primary health care, but I think it is something that is still yet to be solved. Who pays for care coordination?
Thank you. Thank you very much, Dr. Ndileka. This was it was a worthy presentation. I also agree that value-based care is the future in terms of the GP practice. I've recently started doing it, and just to answer the colleague there in the front, you need to have staff that will do a lot of the things that you can do. Not that you can't do, but you don't have time to do them. I have a nurse that does a lot of my work, my chronic management. So I've also equipped my front desk to know that this patient is due for bloods today. They're going for bloods. This one is for renewal of script. So a lot of the things I don't really do. I do the last part that they've already started. But my concern is on what you've mentioned, which is key, that in the value-based care, we need other professionals. I need a dietitian to work effectively. I need other professions. The problem that I'm having is the medical aids don't compensate those. You talk about Kike, you talk about James, Emerald. They don't pay the dietitians. Now you get them, they have to pay rent, but they are not seeing patients. And I need them to see my patients for effectiveness of my practice. But they are not compensated, so they end up leaving. So that is the most challenge we have. I agree with you. We have to sit in those decision-making platforms. But at times we don't have time to sit in those platforms. So that is the challenge when it comes to value-based care and care coordination. Thank you.
Yeah.
Thank you so much for your talk. So I'm with a GP who has a few practices, and we are already implementing the value-based care model. And what it really needs is for doctors to be creative in how they implement this. It can be done. It's just a matter of thinking a little differently to how we are used to doing things. So in terms of having the allied health workers and your multidisciplinary team, instead of you employing them, you add them as like a sessional psychologist. And they pay you a small rental if you have the space, or there are many different ways in which you can get these allied health workers or your multidisciplinary team into practice. So we're already doing that. So our okay.
So last year the rules changed. The regulations around November, and they actually allow us to now partner with other allied services. So you shouldn't be employing the allied services because you're not allowed to be employing them. But so what she was saying about sessional is you don't need to have a psychologist in the space if there's no bookings for them. So essentially your practice, what they would do is if you know and you've picked up patients that require these allied services, then you can group your patients for consultations for a specific day. And then your psychologist comes to see your patients for that specific day. That way you're saving on the overheads to have that person in. But the most important thing is technology. You can't do this without technology. So value-based healthcare is centered around the technology of that, because from there, you can determine what the patient needs, if they need a dietitian and all of that. So if you're looking at all of your patients, then you can group them. And then the funders are actually paying for our time. You mentioned the REPI scores. So you're looking at the REPI scores. Now with the value-based being introduced, some of the things that they have would be, I know Discovery has what they call XCOMS, which is extended consultation. So what they do is for that extended time that you're spending with the patient, it's not 15 minutes obviously, they will pay you extra. But to be understanding your PMBs, because they're directly tied to your PMBs, which is exactly that. So not every extended consultation would be paid as an extended consultation, but it's based on that. I mean, if a patient is coming in and you need to suture, That's not an extended consultation. That's a different consultation to when you are managing a hypertension patient. So if you're managing that hypertension patient, you can actually register it as an ex-com, but then you have to actually manage it and follow up, and that's how you get that 1,200 you spoke about. Because if you are managing your patient, I've tested them last time, and now we're seeing that they're improving. That means you're doing your job as a doctor. And what value-based healthcare is doing, it's actually removing the care from the doctor. It's putting it back in the hands of the patient. And you as a doctor, you actually act as a facilitator of that. I mean, I know they're introducing the World Adherence Day. And the biggest problem that we have is actually adherence. It's not the doctor.
Yeah.
But it shows you that our patients are not educated enough to understand the conditions that they have in order to ensure that they improve their outcomes.
Yeah, yeah. There's also a business model rethink that we need, and partnership. You can't do it alone. You can't employ, as I think she said, you can't employ all these class of clinicians and allies, but you do need to partner. And so how do you partner? And it's through SLAs, right? You can have standard level agreements with a particular, and have certain outcomes or certain quality things that you agree on, and so you access their expertise, but at a sessional, as and when needed, for your patient population.
Wow, this is quite a hot topic. Sure.
Thank you so much, Joey.
You are all most welcome to make contact with Dr. Ndileka afterwards. Dr. Ndileka, thank you so much.
Thank
It
you.
is definitely, we do know that value-based care is a very hot topic.